shall we start or shall we wait for them? Okay. Now, see, primary tuberculosis, secondary tuberculosis, tertiary tuberculosis, you should know the morphological difference because that is reflected in the investigation. That is reflected in the investigation because what you see in the morphology that you see in the X-ray, you will be seeing in the X-ray. So now, and usually you see the primary tuberculosis, the lesion starting in the lower part of the upper lobe and upper part of the lower lobe, which area near to the pleura, that is subpleural area, that is in the subpleural nodule. Usually starts with the subpleural nodule. Okay, then if you see only subpleural nodule, it is called gone focus. It is called gone focus. Then after 3 weeks, it enters the lymphatics and it goes to the lymph node and it goes to the corresponding hilar lymph node. Okay, and what? They can't hear me. Okay, so this is gone focus, and what you are seeing along with the node, it is called gone complex. It is called gone complex. If you see only the subpleural nodule, it is called gone focus. If you see both hilar lymphadenopathy, hilar lymph node involvement, then it is called gone complex. If you see in X-ray 2 areas like this, it is primary tuberculosis. It is primary tuberculosis. Okay, now in X-ray, if it goes for calcification or it goes for complete fibrosis, it is a chronic inflammation, right? So if inflammation is good, it slowly healed, and that is a fibrosis. That is fibrosis. That is called Ranke complex. That is called Ranke complex. Okay, these three together, primary tuberculosis. So when the tuberculosis infection starts, it starts with first non-caseating granuloma. It starts with non-caseating granuloma, then it becomes caseation, because first they form the non-caseating granuloma, then the interferon gamma comes, that will kill the tuberculosis, then it becomes necrotic area, then it becomes caseous necrosis. So it starts with non-caseating, then progress to caseating. So in primary tuberculosis, you have a high chance to see non-caseating granuloma. You have a high chance to see non-caseating granuloma in the primary tuberculosis. So now this person will have cough, sputum, everything, but it is under control. The sputum may be negative for bacteria. Okay, so because the bacteria will be killed and the inflammation will make them to go for fibrosis. Okay, so but they have some kind, because it's happening in the lung, right? So they will have some cough, some kind of sputum, but that may not have the bacteria. Now when the person immunity goes down, then this person can become secondary tuberculosis, or this person first time got infection, primary tuberculosis, then he got healed, then he can travel like 20 years normally, then after that his immunity going down. Understand? Any part of his life, if immunity goes down, the tuberculosis bacilli which is healed, there 1 or 2 bacilli will be there, that will get reactivated, that will become reactivated, and they will form secondary, you understand, that will form secondary tuberculosis, that usually involve the apex of the lung, and it may produce complete caseating necrosis. You understand? It may produce complete caseating necrosis, slowly the patient takes the sputum along with the necrotic area outside, and you can see in that sputum tuberculous bacilli. You can see in that sputum tuberculous bacilli because it comes out. So it comes out, you can see TB bacilli positive in this case. So what staining you do? You do AFB staining, acid fast bacilli staining, that will be positive. That will be positive, and the patient have high symptoms. All the symptoms they will have: cough, sputum, even blood mixed sputum, hemoptysis, and they will also have fever, or loss of weight, loss of appetite. All the symptoms they will have. Okay, then they remove all the things through the sputum, and this will become like a cavity. It will become like a hole in the lung. It will become like, yeah, it is if it is caseation, it is like a cheese like necrosis. Okay, and if the person keeps on removing it, that area become like a hole, empty. So that is called cavity. That is called cavity. So yeah, in secondary, apical lesion, that is apical caseation, it will lead to apical cavity, and the patient will have AFB positive, and it will be of caseating necrosis. It will be of caseating necrosis, that is caseating granulomatous inflammation. That is caseating granulomatous inflammation. That is the feature of secondary tuberculosis. Now, in tertiary tuberculosis, what will happen? Huh? The bacteria spreads all in the blood. It produces seed-like deposit. It produces seed-like deposit in the lung. It is called pulmonary tertiary tuberculosis. It is called pulmonary tertiary tuberculosis. If they produce deposit in the liver, it produces deposit in the spleen, or in the kidney, or in the brain, it is called systemic tertiary tuberculosis. Systemic tertiary tuberculosis. This patient immunity will be very less. Immunity will be very less. Okay, so this patient immunity will be very less. Like for example, 60 cells per cubic millimeter of CD4 cells. Okay, so this all depends upon their immunity. It all depends upon their immunity. So in this patient, okay, you may get MAN2 positive. Okay, MAN2 positive. Okay, so this is all about morphology of pulmonary tuberculosis. Okay, you all understand this? Now what is the next thing we discussed? The next thing the girls asked, I think, regarding the drug interaction with the inflammation, right? Chemical mediators of inflammation. Okay, I think yesterday some students asked about chemical mediators. See, first step in inflammation is vascular changes. Vascular changes. First step in acute inflammation. Second step followed by vascular changes is cellular changes. So this vascular changes and the cellular changes happens due to chemical substances, due to chemical substances, they are called chemical mediators. Okay, the first vascular change is vasodilation, right? This vasodilation happens due to histamine. Okay, I think we recorded the whole session. You can see from the recording also. I don't want to go in detail. So histamine causes vasodilation and increased vascular permeability. So that's what happens. The fluid goes out and the protein goes out. The fluid and the protein goes out. After that, the cells goes out. The neutrophils goes out. Okay, this all is called exudate. This all is called exudate. And in a bee sting, that is the bee bite the person, what happens? That produce immense inflammatory reaction and they produce lot of histamine and the person goes for fluid escaping into the interstitium, that is called edema. That is called edema. So that is why that is the histamine is the answer for it. Okay. So like I told you I was explaining about this process. I told you, like, if you are going for some place and if you get any allergy or anything goes to the nose, immediately you get secretion, right? Running nose. So running nose comes because of what? Because histamine is released, there is vasodilation, that area becomes red. That is called congestion. If you see the if you see the nasal mucosa, if you put a torchlight and if you see in that person, that mucosa will become very red. Even some people, if they are very fair, you can see redness in the nose. That is congestion, that is vasodilation and the increased vascularity and the fluid escapes out, so the fluid coming out, and that's a running nose. Have you heard of running nose? The fluid, watery fluid comes out. So this is due to what? Why? Because of histamine. So that's why we give you a drug called antihistamine. That's why we give a drug called antihistamine. If you give the drug antihistamine, immediately this is stopped. Immediately this is stopped. So this is regarding the histamine. Now, so during the inflammation, what happens? Two cytokines are increased in acute inflammation. What are they? TNF and IL-1. This what it leads to is it goes to the neutrophil. In the neutrophil, they activate the enzyme phospholipase A2. This will break the phospholipid in the cell membrane and they form arachidonic acid. Then there is another enzyme, cyclooxygenase, and that will break the arachidonic acid and they form prostaglandin. This prostaglandin escapes out and it goes in the blood and it reaches the brain and hypothalamus. They increase the body temperature. They produce fever and they also transmit pain. Okay, so now we use two drugs. Okay, one is steroid that will block the phospholipase A2, then complete system is shut down. Okay, very powerful, potent anti-inflammatory agent, that is steroids. But we cannot shut down the inflammation. Okay, because we need inflammation to kill the bacteria, to protect ourselves. So steroids we use in autoimmune diseases. In which disease? Autoimmune disease, where the person's own immunity is destroying his own body. That is autoimmune disease. In some individual it happens. Okay, there are many autoimmune disease. The person's own B cell, own T cell will attack his own tissue. Understand? So that is autoimmune disease. In such person, we want to suppress the inflammation. So we give steroids. Steroids acts on which enzyme? Phospholipase A2, and they block the phospholipase A2. So the whole inflammation is shut down. Whole inflammation is shut down. Now, if you give ibugesic, paracetamol, aspirin, all will block the cyclooxygenase, and only the prostaglandin part is cut. Okay, they will reduce the fever and the pain. Now the problem is, we need in the stomach mucus. We need the stomach mucus, otherwise acid will, HCl will destroy the stomach wall. Okay, so for the production of this mucus, we need prostaglandin. So we need cyclooxygenase. So then the mucus is formed. So when you block the cyclooxygenase, this is also blocked. So automatically the person will get less mucus, and they go for gastritis, inflammation of the stomach, or they go for severe gastritis reflected in a symptom like severe abdominal pain, severe gastric pain in the epigastric region. Okay, so usually this happens. For example, any patient comes to you, like any patient comes to you for some pain, what you give? Painkiller, right? So when you give a painkiller, you should be very careful. You should give a drug which reduces acid secretion, so that mucus secretion will be reduced, acid secretion will also reduce, it will be balanced. Okay, so we give antacids. Sometimes we forgot to give. If you forgot, then the patient will have severe gastritis. And if we keep on continuing, it will produce gastric ulcer. And severe bleeding. Okay, so this is the chemical mediators complication. Okay, when you give drugs dealing with chemical mediators, these are the complications you will get. What? Yeah. So now coming to the cyclooxygenase 1 and 2. Okay, we have cyclooxygenase 1 and 2. Okay, so we have now specific cyclooxygenase 2 inhibitor, where cyclooxygenase 2 inhibitor is not involved here. So cyclooxygenase 2 is specifically involved in the inflammation, but cyclooxygenase 2 inhibitor will produce cardiac diseases. Because it increases the blood clotting capacity. But for your level, this is compulsory. So just you should know at least cyclooxygenase inhibitors. Cyclooxygenase inhibitors will inhibit the mucus production, that will lead to gastritis. So you have to give a drug, antacids, to counteract this mechanism. Okay, so this is all about the cyclooxygenase metabolites. Okay, what is the one responsible for fever and pain? Mainly it is prostaglandin. Okay, so now this is all about the chemical mediators. Any other questions? See, regarding necrosis, morphology of necrosis, somebody asked, right? Morphology of necrosis. See, if the morphology of necrosis is asked in a cases, we would have given some kind of some history. The patient collapsed, or patient went for subconscious and he died, and they will give in the autopsy. If they did autopsy to identify the cause of death, and in that they would have removed the brain, and they would have see the liquefactive necrosis and all. Okay, what is the cause? The most commonest cause for necrosis is what? Most commonest cause for necrosis? Huh? Okay, most commonest cause for hypoxia? Ischemia. So most commonest cause for necrosis is ischemia. So most commonest cause for hypoxia is ischemia. Understand? So then what type of necrosis seen in ischemia? In brain, it is liquefactive necrosis. In the other organs, it is coagulative necrosis. Except in pancreas, if the inflammation of the pancreas happens, acute pancreatitis, the enzymes of the pancreas leaks out. What is the enzyme? Lipase, one of the enzyme which goes and destroy the lipids, so that will produce fat necrosis. See, there are 5 types of necrosis. One is coagulative, liquefactive, and fat, caseous, and fibrinoid. This is not we discussed, right? Not discussed much, but this 4 we discussed in detail. One is coagulative necrosis seen in all the organ. For example, kidney is going for necrosis. What happens? That will produce coagulative necrosis. Hello. Sylvester போய் பார்த்து இன்ஸ்டால் பண்ண சொல்லுங்க. Sylvester. Okay, it is coagulative necrosis seen in all the organ except brain. In the brain, what you see? Liquefactive necrosis. Why liquefactive happens in the brain? It is due to ischemia. Mainly due to ischemia. Coagulative necrosis happens mainly due to ischemia. But if in the other, if it is other than the brain, you see coagulative necrosis in ischemia. If in the brain, you see liquefactive necrosis. You will see liquefactive necrosis in ischemia. Okay. Fat necrosis is seen in a condition called acute pancreatitis, acute inflammation of the pancreas that leads to enzyme lipase increase that cause necrosis of the fat. Here there is no ischemia. It is due to acute pancreatitis. Caseous necrosis seen in what? Which condition? Tuberculosis. Condition seen in tuberculosis. Okay. So, any doubt in morphology? Okay, it's very simple, Yani. So, this is the morphological related questions we can ask in the exam. Okay, now any other questions you want to discuss? Morphology. Okay, regarding the hyperplasia, okay, cardiac muscle cannot go for hyperplasia. Cardiac muscle can go for only hypertrophy. Okay, so I told you girls by putting this diagram, right? This is a right atrium, right ventricle, left atrium, left ventricle. So from the venous side, the blood comes from the venous side to the right atrium. From the right atrium, it goes to the right ventricle. From the right ventricle, it goes to the pulmonary artery, and it goes to the lung. From the lung, it goes to the left atrium. From the left atrium, it goes to the left ventricle. From the left ventricle, it goes to the aorta. Okay. So when the left ventricle is going for systole, contraction, the blood goes into the aorta. So because of contraction, it creates a pressure in the aorta. The blood goes out with some pressure. Okay, that pressure is, in systole it is 120, in diastole it is 80. Understand? That is normal blood pressure of the aorta. That is called systemic blood pressure. Once again I am telling. See, this is 4th chamber of the heart, right? What are they? Right atrium, right ventricle, left atrium, left ventricle. Now from the venous side, the blood enters, right? The blood enters from the venous side to the right atrium. From the right atrium, it goes to the right ventricle. It is all deoxygenated blood. From the right ventricle, it goes to the lung. that is pulmonary artery, that is pulmonary artery. Then it goes to the lung. In the lung it gets oxygenated, in the lung, and it becomes oxygenated blood, right? Then it enters which? It enters left atrium, and it enters the left atrium. Then it enters the left ventricle. Then it enters the aorta. When it has to enter the aorta, the left ventricle contracts. The left ventricle contracts, that is systole. Then it enters the blood, enters the aorta. When the blood enters aorta, when they are contracting, it creates pressure. That pressure is pushing the blood to the aorta. That pressure is traveled. Okay, so that pressure is called systemic blood pressure. When they are contracting, it is 120 mm of mercury, and when they are relaxing, when the left ventricle relaxing, the pressure goes down to 80 mm of mercury. So now if the person is having systemic hypertension, when the person is having systemic hypertension, for example, instead of 120 he is having 160, instead of 180 he is having 100, which means already the pressure here is more. The left ventricle has to compress against the pressure. You understand or not? Okay, the pressure outside is more, so they have to contract with full force, right? So then only they can push the blood outside. So they need muscle strength. So their muscle don't have a capacity to divide. And that's why the muscle goes for hypertrophy. The left ventricle becomes bigger in size. And that is called left ventricular hypertrophy. So if anybody having 20 years, 30 years of hypertension, they will become hypertrophic ventricle. So the ventricular space will be less. So only small volume of blood comes, and only small volume of blood goes out. So that is not sufficient for the circulation. Okay, so the patient will die. So that is the reason for chronic hypertension patient, they go for cardiac hypertrophy. Which side cardiac hypertrophy? Which side this is? It's a left side cardiac hypertrophy. Okay, left ventricular hypertrophy. Okay, so this is what happens in heart. So this is a adaptation. Because when you correct this, they will come back to normal. Okay, so now any doubt in cellular adaptation? Yes, Bashar. You got it? Okay, so any other doubts in? Okay, cellular adaptations. Fatty change happens in alcoholic patient. Fatty change liver happens in diabetic patient. Fatty change liver happens in obesity. Okay, then we discussed about pigments. Pigments is very, very important for oral student. We gave you some article on pigments. Try to read it. Okay, this semester, this exam, I'm not going to ask question from that article. Maybe because inshallah already you feel like overloaded. So inshallah we will ask in the next exam. Okay, so when you have a vacation, you study. I want to tell you girls, anybody can make notes on those article. You can present to us. It's not compulsory. So we will give you a gift. Okay, for the best notes. Okay, so anybody is interested, they can present. Okay, it's very, very important article only we are giving, just to bring attitude of research in you, but we cannot force research in people. Okay, only if you are interested, you do it. Okay, well, definitely we will appreciate your work, and we will put it in our notice board. Okay, so regarding to the pigments, see, there are two types of pigments. Some pigments are formed inside the body. Some pigments comes outside the body. From the outside, if it comes, it is called exogenous pigment. Something formed inside, it is called endogenous pigment. For example, the person is a smoker. Okay, what happens? Normally, the melanin will secrete less amount of melanin. melanocytes. In those persons, the smoke stimulates the melanin to produce more melanocytes to stimulate more melanin. So it produces black color pigment. You see the smoker's lips and even inside the oral mucosa is in black color. So that is due to the melanin. So overstimulation of melanocyte. Okay, now coming to the exogenous pigment. In the exogenous pigment, the most important one is coal. Okay, so the person working in a industries, coal industries, okay, they take lot of coal pigment in the lung, okay, and they will die of the lung disease that is called pneumoconiosis. Why I am telling is, when the person having pneumoconiosis, he will have chronic cough. If he comes to you, or especially in other countries, I don't know about Saudi, in some other countries, South Asian countries, the same condition can be seen in traffic police. Okay, because they are in the always in the polluted area, so they keep on taking the smoke. Okay, so in South Asia, why I am telling is, traffic police will be standing outside. Okay, so they will not be inside the car. So so the traffic police gets more the smoke inside because they regulate the traffic and they will be outside in the road. So they also come with such condition. So when they come with you some conditions like any traffic police, you have to think of occupation related diseases when any patient comes to you. Okay, so because those patients will have less lung capacity, so they will have less oxygen in their blood. Understand? So if all of a sudden loss of blood can cause myocardial infarction and heart attack to them. Hello? Hello? Yes? Yes, brother. I'm in the classroom. Hello? What, brother? What? Huh? Yeah, USB. No, I want, you want me to come to your office? Inshallah, I will come, brother. Huh? After the class. Okay? Hmm. Yeah, that's what I am coming. Even the smokers will have lot of carbon pigment in their lung. Okay, chronic smokers, that's why when they remove the sputum, especially in the morning, you see black color sputum. Okay, it will be not dark black, it will be gray color. It will be gray color sputum. It is carbon in the sputum. Understand? So please keep in your mind, this is more commonly seen in shisha smokers. Okay, so they smoke lot of carbon. So the carbon amount is 100 times more than the regular cigarette. Okay, so that is highly dangerous. Huh? Yeah, it is exogenous. Okay, you are getting smoke from outside, right? It is a exogenous. Endogenous pigment or lipofuscin pigment, because of old age our cells form the pigment, that is lipofuscin pigment, that looks brown in color. The organ goes for atrophy, it is called brown atrophy. It is called brown atrophy. And another pigment is melanin. Okay, these are all about the pigments. And I think please, when you see a case, don't get panic. If you get panic, you will not actually, the case may have 3-4 lines, but actually it will be very easy. Understand? But if you read it, just put your thoughts there and see the answer, you will find the answer. If you become panic, then you will not see anything. So calmness in exam is very, very important. Okay, so we encountered such type of panic in the MBBS students also. Okay, that's what I am advising you girls. It will be very easy. What all the things we discussed, what all the examples we discussed, those only we are checking. Understand? That's only we are assessing. We are not going to assess something like a same example. Understand? So please try to understand, then read the phrase. In case you have 1 or 2 words you cannot understand, ask the exam hall supervisors. Okay, they will, don't ask the answer to them. Okay, so ask the meaning of some words, they will explain to you. and we try to put actually we reduce more terminologies, we explained those terminologies, okay. Like even we didn't gave like myocardial infarction, we gave like necrosis of the heart, okay, necrosis of the muscle of the heart, okay, we explained that, okay. So I don't, because you are in an early period, so we don't want to bring more terminologies in the cases, okay. Most of the terminologies we explained. If you would have missed one or two, like it is like we cannot avoid that, we put the terminologies. Those terminologies if you are not able to understand, you can ask the supervisors, okay, so they will help you. So please keep in your mind, it's all the examples which we discussed, from those areas only we asked the cases, we didn't go anywhere away from that, okay. We reviewed the questions 4-5 times, we even saw heard our videos again, and anything which we are not discussed we didn't ask, okay. So in that way it is very clear, so you all can get full marks actually, understand. And mashallah, females performance is better, okay. So please do well in the exam, okay. So any doubt in the coming week also, try to mail us, okay. In case you want to come and meet us, you can come and meet us by 8 to 9 o'clock, okay. Yes.
I have a question about that woman who she results in the exam. She have autoimmune disease and CPR,
CRP
CR,
is high.
yeah. What's the answer? Correct answer.
What is the choices they gave?
I think she activated disease. She got activated disease.
Yeah, it is a activated disease, okay. It is a active inflammation.
Can you fix it for me?
Yeah. See, in the systemic effect of inflammation slide, in the systemic effect of inflammation slide, I discussed 3 slides. One is fever, right? Second one is I discussed about 3 proteins: serum amyloid A, CRP, another one is fibrinogen. For CRP, it is a direct lab test. We measure the C-reactive protein. It is a direct lab test. If it is increased, it is a sign of active inflammation. It is a sign of active inflammation. If the fibrinogen is increased, but we do a test called ESR. It is a erythrocyte sedimentation rate that will be increased. So when these two are increased, it is a sign of active inflammation. Why I am telling is, the person is in autoimmune disease, we give them a steroid. Why we give steroid? We want to suppress the inflammation, we want to suppress the immunity. So when you suppress the immunity, the CRP we do every 6 months, whether our drug is working or not. If the CRP is maintained normal, okay, which means our drug is working. If the person disease become active, then CRP is increased. CRP will be increased. So it is a sign of active inflammation. You all understand? Okay. Now another thing we discussed is in the third slide, blood cell count. Right? In the inflammation, overall WBC will be increased. Except one condition I told you to remember, in the typhoid fever, the WBC goes for leukopenia. Typhoid fever, the WBC goes for leukopenia. In rest of all the conditions, most of the conditions, the WBC will be increased. It is called leukocytosis. It is called leukocytosis. Then we see what type of WBC is increased. If the WBC like neutrophil is increased, we suspect bacterial infection. If the eosinophil are increased, it is called eosinophilia. Neutrophil are increased, it is called neutrophilia. Eosinophils are increased in asthma, allergy conditions, fungal infection, parasitic infections. And if lymphocytes are increased, it is called lymphocytosis. It is called lymphocytosis, especially in the viral infections, tuberculosis infections. So the lymphocytes will be increased. Any doubt, Bashir? You understood? Any other doubts or any other explanation you girls need? Huh? Classification of calcification. Okay. No, in the lab. Yeah, in this inshallah you study what type of fixatives used in what type of investigation. See, formalin in used in light microscopic examination. Light microscopic examination. Michal fluid used in immunofluorescence examination. Glutaraldehyde used in electron microscopic examination. When you want to send a tissue for light microscopy, you have to send it through formalin. Okay, with how much percentage? 10%. Okay, if you want to send a tissue for immunofluorescent, you have to put it in a Michal fluid and you have to send. Michal fluid is not a fixative, it is a preservative. It is a preservative. And glutaraldehyde is a fixative. You want to send it for electron microscopy, you have to send it through glutaraldehyde. Understand? So these are the three fixatives at least you should know. Okay. So alcohol is a fixative, but we use in the cytopathology, that inshallah we will discuss in the second semester. Okay. Yes. Yeah, that is, this all will be discussed in the practical exam. This all will be discussed in the practical exam. Okay, now coming to the other things what you asked, calcification. So coming to the calcification, there are two types of calcification, right? Dystrophic, metastatic. Dystrophic calcification seen in a patient who's having necrotic tissue. It happens in the necrotic tissue. For example, the person is having tuberculosis. There is a necrosis, right? In those areas, the calcification goes. It is called dystrophic calcification. Here, the tissue is in problem. The tissue is dead. Then the calcium goes and deposit. Okay. So that is dystrophic calcification. Easy to remember. DD. Dystrophic calcium deposits in the dead tissue. Calcium deposits in the dead tissue. The person will have normal blood calcium level. Normal blood calcium level. Whereas in metastatic calcification, there is problem in the calcium. The calcium level is more. There will be hypercalcemia. Because of this, the calcium gets deposited in the tissues. The calcium gets deposited in the tissues. It can deposit in the kidney. It can deposit in the lung. It can deposit in the blood vessels. It can deposit in the stomach. These are the areas they deposit. 4 areas: kidney, lung, blood vessel, stomach. Okay, because they are, that is the alkaline area. So calcium deposit in the alkaline tissue. So what are they? Stomach mucosa and lung and the blood vessel and the kidney. These are the area the calcium deposit. Here the problem is there is increased blood calcium. Increased blood calcium, that is called hypercalcemia. That is called hypercalcemia. So in the hypercalcemia, what happens? There is a metastatic calcification. What are the reasons for hypercalcemia? If there is parathyroid hormone is increased, vitamin D toxicity, if there is lot of fracture. So these are the conditions where you see hypercalcemia. Okay, so any other doubts?
Doctor, there used to have a bus in my,
Okay.
and you say that like leukocytes
Yeah, what type of leukocytes will be seen in the pus?
Doctor, listen, in the acute inflammation, the leukocyte will see the neutrophil and basophil and eosinophil, and you write it out in the chart. So
What in the pus, what you see? Neutrophil. Okay. So in the pus, if you take a pus and if you put it in the microscope, you will be seeing full of neutrophil. Some neutrophil will be living, some neutrophil will be dead.
So doctor, if you ask if the type leukocyte is
Now I would have asked if I'm giving different types of WBCs, and if I'm asking, like if it is a fungal history, okay, fungal infection history, and there is a pus, then you should write eosinophil. Generally, in all the infection, the pus will contain neutrophil. Okay, any other doubts? Somebody from this side they are asking. All, any doubts? Okay, Taif, let us finish this session.